Afternoon and good evening. Welcome to the second Oral and Maxillofacial Pathology online journal club, and it's a great honor for us to host Professor Alena Skalova in this meeting. First of all, I would like to express my appreciation to Oral and Maxillofacial Pathology Department of School of Dentistry and also Cancer Institute Hospital Pathology Department of Tehran University of Medical Sciences to organize this event. And also I would like to thank Appraise to Raise team to support this program technically. It's a great honor for me to get started the second journal club. First of all, let me know that if Dr. Safar, are you with us? And also Kiana and Shabna, if you are with us, I would like to ask you to turn on your... Oh, hello, Shabna, how are you?
Hi, thank you so much.
Hi, Kiana.
Hi, I want to say hello to everybody also, and it's a pleasure for having you all here today.
Great, great. Thank you for joining us. And Dr. Safar.
Hello, everybody.
Hello, Dr. Safar. Thank you for joining us.
Hello, welcome. Hello, dear Professor Skalova. Hello. Really great pleasure to hold the second International Journal Club in our department. Thank you so much, Puyan. Thank you, Dr. Anusha. Thank you, Shabna. And the most important thing is association of Professor Skalova with us today. It's a great pleasure. Thank you so much.
Thank you for welcoming me. It's a pleasure for me to join you.
Thank you, Professor Skalova. I know that no need to introduce Professor Skalova, but let me few sentences about her. Professor Alena Skalova is Professor of Pathology of Faculty of Medicine, Charles University, and also in the Czech Republic, and she's author of several books, several important and influential article, and also she's collaborator of WHO Blue Book, and no need to introduce her, and she kindly accepted our invitation to join us to this meeting and guide us how we can use this important article entitled as data set for the reporting of carcinomas of the major salivary glands to our routine practice in our labs. Thank you again, Professor Skalova. And if you would let us, we can get started the first part of the program with a presentation by Shabna.
Thank you, my pleasure. Please, go on.
Thank you very much. Okay, Shabna, we are all ear to hear your presentation.
Okay, let me just share my screen. Okay. Good morning, everybody. Shabna Mishadi is speaking, and I'm honored to be the first presenter of this webinar as grade second physician resident of pathology at Tehran University of Medical Sciences. This chosen paper is going to focus on reporting carcinomas of the major salivary glands for the international collaboration on cancer reporting, which is shortly named as ICCR. Okay. This collaboration started working in 2011, describing standard data sets and ethnic sites that could be used worldwide. This article concentrates on salivary gland carcinomas, which are not so much common. Besides, the morphological findings between the tumors overlap, making it quite challenging to distinct. And we do make effort to accurately distinguish between salivary gland carcinomas, since it's got a major impact on patients' outcome. Briefly saying, this article focuses on a data set based on both key core elements and non-key core elements, which I will be discussing in details further. To begin with, the ICCR dataset is used for resected specimens and some biopsies, including invasive and in situ carcinomas of major salivary glands. This dataset does not include melanomas, lymphomas, sarcomas, minor salivary glands, and cervical lymph node dissections. The described dataset is based on reporting two main elements divided as core and non-core elements. The first are the core elements, which are critical for staging patients' prognosis as well as their outcome, and should be included in our surgical pathology report. The second are non-core elements, which they are being recommended to be included in our reporting format, since they're good for clinical practice. Okay, now in this section, I'm going to jump to the core elements here. Okay, the five key core elements that I'm going to describe here will be the operator procedure, specimen submitted and tumor site, tumor focality, tumor dimensions, and histologic tumor type. To delve into more details, one of the major core elements are called operative procedure, which they are wide in variety and complexity. Therefore, the exact procedure type, whether excisional biopsy or resection, should precisely be named. In case of recurrence, when there isn't any non-pathologic surrounding tissue, the best procedure designation should be done with the cooperation of its surgeon. Another core element is specimen submitted and tumor site. The article gives an example as a gland, which has two components and should be named exactly as you can see here as I'm showing them. Also, the laterality of specimen is a standard identifier that should be included. The author suggests that the clause not specified should be only used in rare circumstances. Tumor focality also should be mentioned. As we all know, multifocal tumors of salivary glands are rare. There is an exception about the actinic cell carcinoma, which multifocality is common. And about the tumor dimensions, as we know, the largest diameter of tumor is crucial for staging, and it directly affects patients' outcome. The author recommends that the tumor size should be measured in fresh state, while formalin fixation may shrinkage the specimen. As another hint, when there is a significant difference between our gross measurement and microscopic measurement, our microscopic measurement is preferred. As you can see here is a listed table of WHO classification about the histologic tumor types of major salivary gland carcinomas. And basal cell adenocarcinomas and conventional actinic cell carcinomas have local recurrence with low rates of nodal or distant metastasis. On the other hand, salivary duct carcinoma shows high rates of nodal metastasis, leading to a poor survival. Carcinoma exomorphic adenomas are subclassified by their type and their extent of invasion. The minimally invasive carcinomas range between 1.5 millimeters up to 6 millimeters. The invasive carcinomas extend beyond 6 millimeters. Here, the author recommends a full histologic evaluation and sectioning the whole lesion to exclude any invasive growth. The degree of invasion is interlinked with the patient's prognosis. However, in minimally invasive carcinomas, aggressive behavior is still reported. At this slide, you see a figure that at the right side, the figure A depicts minimally invasive myoepithelial carcinoma, exomorphic adenoma, which it invades less than 2 millimeters beyond its capsule. And at your right side, figure B describes a widely invasive carcinoma, exomorphic adenoma, which has a more extensive invasion. The cryptocurrencies carcinoma of salivary gland is a subcategory of polymorphous adenocarcinoma. It's frequent in extrapalatal origins and has high rates of nodal metastasis. Histologically, they present with a vesicular nuclei and have a papillary glomeruloid and cribriform growth. It's recommended to separate the cribriform and classic adenocarcinoma subtypes since they both different prognosis. Okay, thanks for listening to me, and this is the end of my speech. Thank you for your company, and actually, I'm going to pass my time to Dr. Anusha to go ahead.
Okay, thank you very much for presentation of the first part of the article. You know, because of time shortage, we asked Shabna to present it concisely. And let me, first of all, I would welcome other attendees joined us in recent minutes. And I would like to invite them to share their questions in chat box, and they can also directly ask their questions from Professor Skalova. And if they would like to ask their questions directly, please raise their hands and we will turn on their microphone and also videos. First of all, let me ask you, Professor Skalova, I have a question. Let me get started. The first questions myself. You know, Shabna well explained about pleomorphic carcinoma, exomorphic adenoma. You know, there is a challenging topic about the extent of the invasion. Some authors believe that if you would like to name the carcinoma exomorphic adenoma as in situ, it should be the carcinomatous component should be inside the whole tumor. And if you would like to call it as minimally invasive, it should not be extended beyond 1.5 millimeters. Some of them believes that it should be limited in 6 millimeters or 4 millimeters. Would you please share your personal experiences with us about the extension of the carcinomatous component of carcinoma exomorphic adenoma, and how we can call it as an widely invasive carcinoma exomorphic adenoma?
Göran, thank you. Thank you for introduction, and thank you for the first question. I'm very pleased, and it's a real honor and pleasure to be with you. I would like first to express my appreciation to Shabna, who presented her first part very well, and it was pleasing to listen to her presentation. But back to your question, and not to waste the time of all participants, I agree with you, Göran. It's a problem. Personally, I would recommend to follow the measures which you presented, and to call intracapsular or in situ carcinoma, exomorphic adenoma, only for those malignancies that definitely do not extend beyond the major pleomorphic adenoma, the original tumor. It's sometimes quite difficult to appreciate. The resection specimen must be complete, and as you all understand, that it's not always the case. It depends on the procedure. So I would agree with the numbers, 1.5 and 4 millimeters more for widely invasive. And I would, in addition, just like to emphasize the type of carcinoma arising from pleomorphic adenoma. We all are speaking, and we are well familiar with the situation where carcinoma ex pleomorphic adenoma is a high-grade malignancy, like salivary duct carcinoma, and it's wrong. It's a really bad, aggressive tumor. However, I have found that quite a lot of examples of myoepithelial carcinoma may arise ex pleomorphic adenoma, and this is really challenging situation, which must be also considered when we describe carcinoma ex pleomorphic adenoma.
You mean that designation of the carcinomatous type?
Exactly.
For example, if it is a myoepithelial carcinoma or polymorphous adenocarcinoma or adenoid carcinoma is more important than the extension, or both of them are important to make the to understand the prognosis of the patient.
Absolutely, Puyan, that's exactly what I meant, that describing the histological subtype of carcinoma arising ex pleomorphic adenoma is extremely important, both of them, the extent of invasion and the type. I would like to say that in my experience, there are three major carcinomas arising ex pleomorphic adenoma: salivary duct carcinoma, adenocarcinoma not otherwise specified, and myoepithelial carcinoma. Surprisingly rare, you can see adenoid cystic or polymorphous adenocarcinoma arising from pleomorphic adenoma. Just these three: carcinoma, adenocarcinoma not otherwise specified, salivary duct, and myoepithelial carcinoma are the three major subtypes of carcinomas arising from pleomorphic adenoma.
Okay, great. Thank you for your explanation. And Dr. Safar, are you with us? I think you had a technical problem at the hospital. If you are with us, we are waiting to hear about your experiences, about, yes. Dr. Safar, I can see your video, but I think, Elmira, would you please make Dr. Saf? Okay, great.
Can you hear me?
Yes, yes.
I'm on. I'm on mute now. Can you hear me?
Yes, yes.
Also.
Yes, we have your voice.
Can't you hear me? Okay, I would like to. I would like to ask another question from dear Professor Skalova. Dear Professor, one of the main key core elements that we have to mention in our pathology reports is tumor focality. And sometimes in determining tumor focality, I myself, it's mentioned about actinic cell carcinoma but sometimes I find that, for example, we have a bulky mass of actinic cell carcinoma, but at the same time, we have small nests in intraparotid lymph nodes. Regarding some benign tumors like Warthin tumor, I have read in your valuable book, and you have got a very beautiful picture image of that Warthin tumor, that particular multifocal type Warthin tumor is seen, for example, in small focus in intraparotid lymph node, but we call it multifocal Warthin tumor. We don't call it metastasis to intraparotid lymph node. But when we are speaking about some carcinomas, low-grade carcinomas like actinic cell carcinoma, if we see some small nests of actinic type cells in intraparotid lymph node in association with a bulky mass of actinic cell carcinoma, how can we interpret this? Is this a metastasis, or this is still a multifocal actinic cell carcinoma? I would be more than thankful to have your explanation, dear Professor.
May I reply? My answer is just modest and humble. I don't know, but I report this as multifocality. It's so rare. I agree, Hannah, with you that much more commonly we see multifocal tumors in the case of Warthin tumors. We are familiar with this, but to have multifocal malignancies, it's really rare. And I would prefer, direct answer, I would prefer to call multifocal actinic cell carcinoma, I would prefer it to metastasis. It's not metastasis if you see small focus in parotid gland close to primary tumor and no invasion, no lymphovascular invasion, for example. I would call it multifocal. But look, also my experience is quite limited. I have seen just one case. I was simply just one case. Quite recently, there was actinic cell carcinoma with several, just actinic cell carcinoma 1 and several Warthin tumors around. Yeah.
Thank you very much for your explanation, for your great answer. Actually, I have experience of just one case, but it was really challenging for me. And at the end, again, after searching the articles, and I found that the actinic cell carcinoma can be multifocal, I decided to call it a multifocal actinic cell carcinoma instead of actinic cell carcinoma with intraparotid lymph node involvement. Thank you so much. Thank you so much. But thank you.
Okay, great. And I think Professor Skalova, it was a great question about tumor focality. It means that it is necessary to have both, for example, pleomorphism and also perineural invasion or lymphovascular invasion to call a nest of tumor in the lymph node or next to a lymph node to call it metastases. And without these features, you suggest us to consider it as a multifocality. Is it true?
Exactly. That's true.
Okay. Great, thank you. And I think that we have Professor Nasser from US, and it is a great pleasure for us to have him. Professor Nasser, thank you again for joining us. And I would like to invite you to contribute to this discussion on the reporting of carcinomas of major salivary glands.
I'm humbled, Professor Porian. Professor Skalova and I know each other a while ago. Good to see you again, or even virtually. How are you? I hope you're doing well. I think with actinics, I think it's very tricky. Actinic cell, in addition to multifocal, in my humble experience with several cases throughout the history, I see actinic, SNI can be, you can have SNI rests just simple normal acini within the lymph nodes and within other parts of the head and neck. So with the specific tumor of actinic cell carcinoma, somebody has to be very careful specifically, but the multifocality is much, much more than having it metastasis. It's a low-grade tumor. It's even stays confined within a capsule almost always. I don't, you know, I stand corrected by the expert that's teaching us today, but I find it to be a very low-grade tumor that's not as aggressive as it'll be more multifocal, accepted multifocal rather than a metastatic tumor. But the rest within just acini, parotid acini, serous acini within lymph nodes and sometimes within muscle, it has to be always kept in mind, although very rare. I had 2 cases since I've been in Oregon, for example, that wasn't one in the lymph node and was in the muscle, and it has to be kept in check. That's not always metastasis. Other tumors are different, but actinic cell could be very tricky. And I again,
yes. Thank you very much for that contribution. I completely agree. I forgot to say that we have also to have in the mind these inclusions, epithelial inclusions within the intraglandular lymph nodes. Yeah, this was absolutely wonderful correction or participation. Yes, I agree.
Thank you, Prof. Skalova. Good to see you again. Lovely to see you.
Okay, great. Thank you very much. And if you would let us, we can get started. We have no more questions so far. And if you would let us, we will get started the second presentation by Kiana. Kiana, are you with us yet?
Yeah, can you hear me?
Yes, great.
Thank you.
Waiting to.
So yeah, of course. Hello again, everyone. I'll be presenting the second part of this informative article. So let's discuss the further core elements for reporting salivary gland carcinoma. Histologic tumor grade is an independent predictor of tumor behavior and has a positive correlation with clinical stage, and also has a positive effect on therapy. However, due to individualized intrinsic biological behavior, grading only exists for limited tumors such as adenoid cystic carcinoma, mucoepidermoid carcinoma, adenocarcinoma, and polymorphous adenocarcinoma. And the grading is implied by tumor histologic type. As an example, here you can see a pattern-based grading in adenoid cystic carcinoma. On the left, you can see a tubular and cubiform growth pattern, and on the right, a more aggressive solid growth pattern. Again, here you can see 2 different gradings for mucoepidermoid carcinoma. On the left, there is a low-grade, well-circumscribed cystic carcinoma of palate with mucous cell-rich areas, and on the right, a solid, highly infiltrative parotid tumor with intermediate and epidermoid type cells. High-grade transformation or dedifferentiation, defined as a progression of a typically monomorphic carcinoma into a polymorphic high-grade carcinoma. It is well characterized in actinic cell carcinoma, adenoid cystic carcinoma, and epithelial myoepithelial carcinoma, and is seen rarely in secretory carcinoma and polymorphous adenocarcinoma. Due to its more aggressive nature, it has more aggressive clinical course and thus needs more aggressive treatment. Again, here on the left, you can see a tubular pattern adenoid cystic carcinoma dedifferentiating to a polymorphic adenocarcinoma. And on the right, an actinic cell carcinoma demonstrates high-grade transformation to a high-grade adenocarcinoma. Perineural invasion usually establish a malignant categorization. Involvement of a specifically named nerve, such as facial nerve, is incorporated into staging and is assigned a more advanced stage. Also, including the extent of perineural invasion, localization, and size of involved nerves can be prognostically relevant, but these factors are not considered as a core element. Lymphovascular invasion is nearly always diagnostic of malignancy except for metastasizing polymorphic adenoma. Right now, existing data are limited, but they support the prognostic value of lymphovascular invasion. Also, the significance of the distinction between vascular and lymphatic invasion and the extent of vascular invasion is not known. Extent of invasion is also another essential core element because macroscopic extraparenchymal extension of stage tumor to T3 and involvement of bone, skin, and facial nerve define a stage T4A. In these both pictures, you can see a dermal involvement of a parotid salivary duct carcinoma and bone invasion of a minor salivary gland high-grade mucoepidermoid carcinoma that both defines a stage PT4A. As we all know, complete surgical excision is the primary mode of therapy for salivary gland cancers. Positive surgical margins increase the risk of recurrence and decrease the rate of survival. Reporting the distance of margins but is considered as a non-core element. A specified critical distance of tumor can have a prognostic difference depending on tumor type, major salivary glands involved, and border. For example, adenoid cystic carcinoma has an infiltrative border and a high propensity of local recurrence. Therefore, even with more than 5 mm of clearance, approximately 20% of adenoid cystic carcinomas recur. On the other hand, epithelial myoepithelial carcinomas are almost always cured if margins are negative. Extracapsular dissection is a conservative procedure usually done on superficial parotid gland tumors due to their closeness to facial nerves. So these tumors are closed with the tumor capsule forming the deep margins. But increased risk of local recurrence is not clear. On the contrary, limited data on this procedure for salivary carcinomas suggests a favorable outcome even with closed margins, because usually these tumors are slow growing and have a low grade. Pathological staging is another core element. Clinical classification is done before the treatment during the initial evaluation of the patient or when pathology classification is not possible. Pathological staging is usually performed after the surgical resection of the primary tumor, and it depends on pathologic documentation of the anatomic extent of tumor and whether or not the primary tumor has been completely removed. PT refers to pathology classification of a primary tumor that has not been previously treated, and it is based on clinical stage information gained by operative findings or gross and microscopic evaluation of the resected specimens. PN entails removal of nodes adequate to validate lymph node metastasis, and PM refer to microscopic examination of distant lesions. Several non-core elements are derived from core elements, including specifying the number of tumors, additional tumor dimensions, salivary duct carcinoma variants, distance of carcinoma components from tumor capsules in carcinoma polymorphic adenoma, characterization of location, degree, and size of nerves involved, and involved margins, closest margins, and distance from closest margins. Coexistent pathology is another non-core element that is not currently oncologically relevant, but mentioning it can be useful. For example, tumor-associated lymphoid proliferation can be mistaken for a lymph node, or in case of actinic cell carcinomas, the presence of a prominent tumor-associated lymphoid proliferation can indicate a more indolent tumor. Ancillary studies, including histochemistry, immunohistochemistry, and molecular analysis, are also considered a non-core elements, and they are used to refine diagnoses. Yet they are not strongly validated as a standard of care. Also, chromosomal translocation can be useful for defining certain tumor types. In conclusion, salivary gland carcinomas are usually treated with a straightforward resection. However, the challenging part is due to histologic diversity, grading, and capturing high-grade transformation. Ancillary testing is gaining prominence, but is not yet part of the core assessment. Generally, developing an internationally standardized data set to simplify and unify the examination and reporting of these tumors is essential. So the ICCR dataset authoring committee agreed on 12 core 2 distinct non-core, and several other non-core reporting elements. Comments are always encouraged, especially in the presence of unusual findings, and consistency can be improved by using a checklist. The goal of the ICCR is to develop a generic evidence-based structured cancer reporting data set in order to facilitate comparison of data between different countries and for future researchers. And finally, regularly reviewing the ICCR data sets in line with revisions of WHO classification and updates of staging manuals are always recommended. Thank you all for your attention and for your time.
Okay, great. Thank you, Kiana, for your nice presentation. And I think we have about 30 minutes to have a free discussion on these topics. Let me again get started the second question panel with my question that Professor Skalova, you have published an important, another important article on the differentiation of salivary gland carcinomas. Would you please give us more details about it? I think it is an important topic in reporting salivary gland carcinomas, and it is mentioned separately in a College of American Pathologists, draft, but it is included in histologic tumor grade. What do you think about it? How a pathologist is supposed to report the differentiation in his or her path report?
Again, let me start my my short contribution by expressing my gratitude and thanks to Kiana for nice presentation, which was clear and very professional. I appreciate it. Thank you. The question of de-differentiation, so-called, or I prefer the term high-grade transformation, is extremely important, I mean, in salivary gland pathology, because as Professor Nasser mentioned, quite a few of carcinomas arising from salivary gland tissue are low-grade tumors that can be managed, let's say, and that they do not provide a great risk for the patient, but quite opposite is the situation where this low-grade malignancy is changed and acquired the feature of high-grade carcinoma. So I would like to divide my answer to two points: how we define high-grade transformation and what's the significance of it. I have been interested in this phenomenon of high-grade transformation. We published this phenomenon in actinic cell carcinoma, also in secretory carcinoma, and I know in consult cases I have seen it in quite a few of cases. We defined it. The tumor should have two components. There should be real evidence of original tumor, of the diagnosis, most commonly in actinic cell carcinoma. So we can see really actinic cell carcinoma being the one component of the tumor. And then in addition to that, we see a separate component, which is high grade, which is non-differentiated, which loses features of actinic cell carcinoma. It's the border is usually very well developed. It's a sharp margin, so it's not, let's say, grade 3 actinic cell carcinoma. It's really actinic cell carcinoma low grade with a component which is high grade, usually non-specific carcinoma that loses the features of original malignancy. The same happened in our cases of secretory carcinoma. When we published the paper in HESP, there were 3 examples, 3 cases. However, nowadays I have seen up to 10 cases of these kind of high-grade transformation of secretory carcinoma. Well, and now the second part of my reply, the significance is really high, because while actinic cell carcinoma low grade is usually associated with a good prognosis, good clinical course, most patients are cured by surgery, and that's it. These patients with high-grade transformation do not have a good life. This is really very aggressive malignancy, and we have seen, and it's important to be aware of the fact that even small part of the tumor, if there is high-grade transformation, even less than 5% of the tumor mass with this high-grade focus usually worsens, or quite definitely worsens prognosis. Therefore, it's evident that even low-grade malignancies should be examined very carefully, but fully. The whole tumor should be examined. Yeah. So that's my answer.
Great. It means that the dissection, the appropriate dissection of the specimen is very important, especially for the residents to provide multiple sections of the specimens to identify if there is any high-grade transformation in the specimen. Thank you for well-descriptive reply. And Dr. Safar, are you with us? Do you have any comment of high-grade transformation or question about this topic?
Hello again, everybody. Thank you so much for your question. It was really great, and thanks, dear Professor Skalova, for her comprehensive explanation. I have got another question. I think, can I ask another question about another type of salivary gland tumors?
Sure, definitely, please.
Dear Professor, sometimes regarding myoepithelial tumors, for example, we have got a well-defined myoepithelioma, but sometimes peripheral borders are not that much smooth. And sometimes I see in some specimens a bit irregularity, and it's sometimes difficult for me to distinguish that is this tumor really encapsulated or well delineated, or I can see some parts of irregularity and a small foci of capsular invasion. Since the diagnosis of myoepithelial carcinoma sometimes just stands to the presence or absence of peripheral borders, I would like to know that in these circumstances, some reference books like Fletcher, Tumors Fletcher, describes that some terminologies like myoepithelial neoplasm of uncertain malignant potential can be used. But this terminology seems somehow vague for the clinicians, and they expect us to define it more clear for them. So, in your, I know that you have a great experience and a valuable experience of following your patients. In these circumstances, as I searched, I found that most of the time when the tumors are rather well delineated and we have just have foci of irregularity and focal capsular invasion, these tumors are going to behave indolently. So what is your experience, dear Professor, and how do you call them, and do you have you ever used the terminology myoepithelial neoplasm of uncertain malignant potential, or you prefer to call it in another way? I will be thankful to have your explanation. I'm going to
Thank you, Hannah. It's 100 questions, and I very much agree that it's extremely difficult. This is really challenging situation, and I would like to say, surprisingly, I supported this view. What Hannah said, what Professor Safar was explaining, it's really great problem, because I'm receiving consult cases. This is one of the most common topics of consult questions, I would say. How to call these proliferating myoepithelial tumors where you are not sure if it's already myopsia carcinoma or just a little bit multifocal myoepithelioma. Okay, and moreover, Professor Safar did not mention that sometimes you can see really increased proliferative activity in those tumors focally. You can see distinctive nuclei. You can see sometimes even necrosis in small necrotic foci. So how to call it? Of course, we do not know. There is not a very good study of these cases, and we are honestly we are preparing the series of such tumors to publish some kind of opinion. There is a very old paper written in 1994 where Gary Ellis used the term atypical myoepithelial, atypical pleomorphic adenoma, atypical myoepithelioma, but this term atypical or dysplastic is not generally used. So at the moment, I really recommend to try to use approved terminology, which means myoepithelium benign, pleomorphic adenoma, myoepithelial rich, like benign, and then myoepithelial carcinoma. In addition, myoepithelial carcinoma is again problematic because there is no really well-established grading for myoepithelial carcinoma. It should be done as well. So my answer is I don't know. These cases are really difficult. My experience is that these tumors recur, and you really need to have a good surgical margin around. And it's a tumor, it's a malignancy, it's a myoepithelial carcinoma. Yeah. With all respect to Professor Safar, what she described, we are speaking about the same group of tumors. I call them myoepithelial carcinomas.
Thank you so much. Thank you so much. Great. So you prefer not to use the terminology of myoepithelial neoplasm of uncertain malignant potential. So, yes.
Not really, because it's not established terminology. Of course, I can give it into the comments. I can okay, it's a myoepithelial carcinoma, most likely. It's well differentiated. There is a that or this myoepithelial cellular proliferation with MIB index of this or that, the suspicious invasion. You can use your descriptive imagination, but I would call it myoepithelial carcinoma.
Many thanks. Many thanks.
Thank you.
Great. Thank you very much. You know, we are looking for some entities between, for example, pleomorphic adenoma and carcinoma, ex-pleomorphic adenoma, or we are looking for entity between myoepithelioma and myoepithelial carcinoma. And as you well explained that we call it, for example, atypical pleomorphic adenoma, atypical myoepithelioma, and I think it means that it is not well accepted by investigators and professors like you, and you suggest us to mention it at the note, at the comments at the end of the path report. Okay, thank you very much.
Professor.
Okay, thank you very much. And we have another question from Samira. Samira, are you with us?
Yes, of course. Hello, everyone. Hello, Professor Skalova. It's my pleasure having you in this great webinar, and it's my pleasure speaking with you. And also, I have a special thanks for Dr. Shakib to make this opportunity for all of us. And I have two questions at a time, Dr. Shakib.
Yes,
can
please.
I have two questions? Yes, thank you. The first one, Professor, is about the ancillary studies. Following the second presentation from Kiana, I think, it's my question that how much ancillary study can help us to make a definitive diagnosis when we facing with a malignant tumor, salivary gland tumor with a spatial histomorphologic features. For example, when we're facing to a salivary duct carcinoma with typical histomorphologic features like comedone necrosis, like in cellular and nuclear atypia and large nest and features that is special for salivary duct carcinoma. Is it necessary to make a definitive diagnosis without any ancillary study, and how much ancillary study can help us in this tumor? If you answer me, it's very pleasure for me.
Yeah. Thank you for the question. I very much appreciate, because this is a great question. We decided when writing data set for reporting of carcinomas of salivary glands, we decided to put these ancillary studies into non-core elements, because simply there are not so very many studies, and it's for this purpose, we decided like we decided. Anyways, there are certain, I would like to start in different way. We all understand that absolutely correct histological typing, I mean correct decision of the histologic subtype of malignancy is of paramount importance. So the finding of correct diagnosis is the major thing. And for that purpose, we have to use some ancillary studies to be sure. For your question, to reply your question, of course, diagnosis of salivary duct carcinoma is important because it's an aggressive malignancy, most aggressive. I would recommend to, even if the histology is quite typical, let's say, I would recommend to use at least androgen receptor CK7 P63. Why? Because the features you described very well, yeah, polymorphism, presence of comedone necrosis, you may have it in metastasis, for example. High-grade tumor from other place may look like salivary duct carcinoma and its metastasis, and then adenocarcinoma not otherwise specified. So for real good and solid diagnosis of salivary duct, I would just use 3 markers. Positive staining for androgen receptors, positive CK7, and negative for P63. And it's not expensive, and it's very valuable. And in similar approach, it should be used for the other malignancies as well. Of course, sometimes, like actinic cell carcinoma, if it's typical, you do not need anything. But if not, you would like to distinguish secretory carcinoma, for example, and distinguishing secretory or mask, when we describe this as a mask, mammary analog secretory carcinoma, to differentiate from actinic cell carcinoma, you need, again, just 3 markers, S100 protein, SOX10, and DOC1. And if you have just these 3 markers, you are safe on the basis of diagnosis, differential diagnosis between actinic cell carcinoma and secretory carcinoma. And that's it. And maybe you would also like to ask about molecular testing. Okay, I am somehow really great supporter of molecular testing in salivary gland carcinoma with many publications, you know it. However, for general practice, for routine practice, you really do not need many molecular tests for a distinguishing of salivary gland carcinomas. I do myself a lot of testing because most of my practice is consult practice, and for consult cases I use molecular testing. As we know, there are type specific fusions, and it's really good to have a molecular support for unusual cases, challenging cases of adenoid cystic carcinoma, for example, with MIP and FIP fusion gene or the other genes which could be commented. We are happy in diagnosis of salivary gland tumors because these fusions are type specific. very, very, very strongly type specific.
Yes,
Right.
thank you for good recommendation. It's very benefit for me. Thank you so much. And Dr. Shakib, Dr. Safar raised hand and
Yes. Thank you very much for your
maybe
question.
also I have another question, but I think maybe Dr. Safar have a recommendation or comment about my question.
Yes, I think we have about 10 minutes. Professor Skalova told me that she has to leave the meeting in 10 minutes, and we have to consider this time shortage. Thank you, Samira, for sharing your questions. Dr. Safar, do you have any comment?
No. I just wanted, because my question was related to Samira's question. I raised my hand. Sorry, I don't want Samira not to ask her second question at all. I just wanted to ask, dear professor, some markers have also therapeutic significance. For example, regarding salivary duct carcinoma, do you recommend using markers like HER2 beside androgen receptor because of their therapeutic significance?
Thank you, Professor Safar. Good question. I think androgen receptor is much more prevalent in salivary duct carcinoma. Head to know is important for possible treatment. My experience is that not all salivary duct carcinomas really express head to know. It's more than in breast ductal carcinoma. It's about 20-25% of cases in my experience of salivary duct carcinomas with head to know overexpression and amplification. So I would, if I have two markers to be used, just one of them, I would recommend to start with androgen receptors for supporting diagnosis. And if there is a clinical need or clinical question for treatment of the patient by anti-head to know treatment, trastuzumab or whatever, I would then use head to know overexpression immunohistochemistry or fluorescence in situ hybridization to provide evidence of amplification of head to know.
Thank you so much. Sorry, Samira. Sorry again.
I think that.
You're welcome.
Thank you so much, dear professor.
Thank you for sharing your question. And let me ask Professor Nasser, are you stay with us? Do you have any comment about immunohistochemical staining for diagnostic or therapeutic approach in salivary gland carcinomas? Do you have any comment or recommendation?
Thank you, Professor Poyen. I agree with 100% with the Professor Skalova. IHCs really help. I mean, P63, P40 in some situations. My epithelial markers, I do use once in a while, basal cell adenocarcinoma, basal versus others, but I agree with her. I think you are the leader in the future with the molecular, with molecular uses for probably the most published among all, and using molecular to identify further features of salivary glands tumors. I have a lot of issues with the ERPR with salivary duct carcinoma versus salivary breast, versus breast carcinoma when they metastasize. It can cause a dilemma, and you have to go further and do a lot of examination. I was going to ask you about the staging, Professor Skalova. Who do you think should do the staging? In some institutions, oncologists and radiologists or surgeons do the main staging. In other institutions, pathologists like to do the stagings on the report. In your institution, in your experience, who really should do the staging? I know it's not easy.
What's my opinion? We should yes, maybe your opinion is even more valuable than mine. Definitely, pathologists have to make some kind of. It's a part of report. We have to make staging, but not clinicians should have a clinical staging. Pathologists have to have a P staging. So both these have to collaborate. I believe very much, because not always are all TUMS in the hands of pathologists. We may have just limited material or fragmented material. In my case, consult material where I get only part of the tumor, and the question is, tell me what's the name of the tumor, and I'm not the one who is asked to make staging. So the answer is like this: both pathologists and clinicians should collaborate in staging, because this is important for the patient, of course.
Right. Sure. Ultimately, the treatment is gonna be the most important. The prognosis based on the subtype. I agree with you 100%. I just want to say, Professor Porian, thank you for letting me participate and listening to the great speakers this morning. Just beautiful session, just a lot of knowledge, I learned a lot from you all, and I'm really humbled to be here. Appreciate the participation. Thank you.
I do appreciate your great contribution.
Thank you, Professor Nasser, and I really very much hope to meet you.
I would love to see you again, Professor Skalova. Great to see you always. Thank you. Thank you.
And Professor Porian, my good friend, I am very pleased and very honored that you invited me actually for this great. I privately told to Professor Porian that I really extremely evaluate or assess, appreciate highly this idea of doing this kind of sessions where residents, but so excellent residents, provide the more major informations, present in this wonderful way how it was done by Shabna and Kiana. Both presentations were just wonderful, and I only have to say that it's a great idea. And my apologies, because we mixed a little bit. I saw that we have one more hour, but at 11 of my time, which is within 30 minutes, I have to give my lecture to my medical students, which are more than 200, and they are waiting for me. So I have to move to the other department. Anyways, it was absolutely great pleasure, and I believe that you will enjoy the discussion maybe after I leave the session, and you can continue with Professor Nasser and Professor Porian and the others. So that was great pleasure for me, and see you sometimes. Bye.
Thank you, Dr. Ashraf. Please wait for 1 minute. We would like to share some certificates of attendance, and we will have a group photos at the end of this part. Zohre, are you with us? Elmira, would you please share the certificates now? Elmira, Zohre, are you with us? Okay. Great, Professor Skalova. No need, no words to explain my sincere appreciation. And thank you for sharing your great experiences and knowledge with us. Thank you very much.
Oh, that's great. Thank you.
I will send it to you by email soon.
Good, great, thanks. Thank you, Porian, for organizing this session for everybody. That was great experience. Have a nice day all.
Thank you. And the next one, please. Okay, Dr. Safar, thank you very much for being with us. And also the next one.
Yeah.
Shabnam. Really pleasure for me, Porian.
Thank you very much. Shabnam, are you with us yet? Thank you for your time and great presentation. And the last one.
Welcome. It was my pleasure to spend my time with you.
Thank you very much. And the last one for the Kiana. Thank you, Kiana, for being with us here. And this is the end of this meeting now. And I would like to invite everyone for the last group photos. And thank you, Professor Skalova, for sharing your time. And everyone, Professor Nasser, thank you very much. Everyone, thank you very much and have a nice day.
Bye-bye.
Bye-bye. Have a nice day. Bye-bye.